I would like to speak about another subject. I would like to speak to you about setting up a new rehabilitation team. A great number of central issues will face those involved in building a rehabilitation unit for TBI. They are clinical, organizational, and numerical. The clinical issues deal with the nature of the clinical population and the services delivered to it. The organizational problems concern the most important problem, the structure of service delivery. And the numerical issues concern the most appropriate way to create a database, including the process and efficiency of service delivery. We have to tackle these points, and then I may present you one program running actually in Mulhouse for going back to work. This is called Omega program by the patients. But at the beginning, I would like to speak about the clinical aspects. The population served can be divided into 3 periods according to time post-injury. The first time period immediately after the injury is a medical one. This period is heavily dependent upon acute medical care. So your team must be built up with medical doctors, neurologists, neurosurgeons, neuroorthopedists, internists, physiatrists, and so on, and not with other professionals. The second period of time begins when the patient is more or less stable and no longer dependent on medical support. It is, I believe, the rehabilitation stage. And the third one involves re-entry back into the community. And during the second period, you need professionals, especially psychologists, neuropsychologists, speech therapists, much more than medical doctors. And in the last period, during you are building up return to the community, to their family, you need social workers, and if they go back to work, job coaches. So you see that your team is complex and modulated, and you have to change your team in function of your population. I encounter a problem in France, in my team, because in France we culturally depend on doctors. So if we have a team in a rehabilitation center which is directed by a psychologist, it's much more difficult than to be directed by a medical doctor. We don't need a medical doctor at the second period, but culturally in France, if somebody has to ask a question about the trainee or about the team, he asks the doctor and not another professional, not a speech therapist and not a physiotherapist. So it's very difficult. But technically, it's not necessary to have a medical doctor. I mean, in the States, the teams I visit were always directed by psychologists and not by medical doctors. I don't know how it is in Greece, but maybe in the Mediterranean countries it's the same as in France. But it's not a necessity. The second problem is the organizational aspect. The organizational aspects center around staff. What kind of staff? What proportion of different staff should be hired? How can skilled staff be found? Many unskilled staff members can be trained and supported. This is the core problem of the leader of a new unit. For example, you can find a lot of staff members in different disciplines, skilled people, motivated people, but without any experience on brain injury and brain injured people. They bring them inappropriate experience which they try to apply to head injury. If you are involved in mental retardation or in children, you are not obligatory a good specialist in brain injury. You must be skilled, you must attend seminars, and you must work very hard to be a new professional. That's to say that the team director must organize presentations, lectures, seminars, attendance at workshops, conferences, and meetings concerning TBI. He must give time to his co-workers to go to these workshops. It's always argued by the stakeholders that such units, like neurorehabilitation units for TBI, are too expensive. But the cost of failing to do it may be even more prohibitive, with reduced quality of service delivered and increasing in staff turnover. I mean that this question is always central for the stakeholders. It's too expensive. We cannot do that. It was, as I began 15 years ago, it was this question. Today is a question. I am retired, but my students are going on with this experience. And it's the same question, it's too expensive, it's too expensive. You don't need a lot of people turning around the TBI person. What I found was an organizational process. At the beginning, my co-workers were against this new process. But progressively, they were interested in this new organization. In my team, one of the professionals, for example, a speech therapist, but also a psychologist or neuropsychologist, each member of the team is involved in the case management of one trainee. We have a group of 8, maximum 12 trainees, and each of our group is the case manager of one of them, okay? But at the same time, the professional is in charge either individually or in group of the whole group. So if I am a speech therapist, I have to do speech therapy, either individually or in group, with groups therapy, but I am also, at the same time, case manager of one of the trainee, okay? And at the beginning, they were not... Huh?
Trainees are the patients.
Trainees are the patients, yes. Do you understand? I'm clear? Okay. And this is interesting because we have an horizontal organization of the work and not a pyramidal construction. We work with the technique of micro projects. You can ask Jim Malek. He knows very well these micro projects. It's an old technique building for Alzheimer patients in 1972. But I use this technique for my patients. I give to the patient, to the trainee, 5 projects. He has to choose the projects, micro projects. At the beginning, he says, my project is to be happy. Well, so I don't agree, of course. I ask him, give me a micro project. So he gave me, for example, 5 micro projects: wake up on time, washing correctly every day, looking at my logbook, looking at my emails, turning off my cell phone during courses, and so on. And they have to classify I need help. Selon l'importance? According to the importance. Thank you very much. And they have to give me the time during which they are able to make the project. 1 month, 2 months, 3 months, 4 months, and so on. And then I ask them, or the case manager asks them, after 1 month, if the micro projects are achieved. And I gave 0 if it's all right, +1, +2 if it's better than expected, or -1, -2. So I can give this paper to the trainee, but also to the family and to the stakeholders, so they see what we are doing. What we do is to help the patient to come from functional independence to autonomy with adaptation techniques, compensation techniques, and with the holistic approach of Benichet and Prigatano. Before I present you the Omega program, not the Delta program. This is my first program. I would say I tried also to make a database, because if you have patients all 6 months, you must register your results. And this was failing in my team, because we have not enough money to ask a manager for informatics, and so we have no database actually, and this is a fault in my opinion. So if you build up a new team, you must have a small database for registering your results. This is very important. So the Omega program, what is the Omega program? The Omega program is a program devoted to go back to work. It's a program destined to trainees with a good outcome, socially outcome, who wish to go back to work with a good autonomy in everyday life. So they are independent, they are able to eat alone, to make their toilet and so on. But if they ask to go back to work, they were fired out. The program is running in Mulhouse, and we accept approximately between 8 and 12 persons during 6 months. It's a modular program. Each module is broken up into several sequences. Sequence 1 to 4 for setting up the vocational project and internal check of the project. We try to assess the situation prior to the accident. What is this man doing on his job? What was his job? And then we assess the situation between the accident and the training program. What is he trying? And then we assess the medical sequelae with the EBIS document. The duration of coma, the Glasgow Coma Scale, the duration of post-traumatic amnesia, the motor cerebellar sensorial sequelae, the existence of seizures, psychoaffective problems, anxiety, depression, stress, addictive behavior, absorption of anti-epileptic and psychotropic drugs are logged as well. More interesting than quantitative analysis of test performances are qualitative analysis and the strategies used when running the tests. The parameters we try to define to assess the chances of a successful return to work are the following: manual dexterity, lateralization, speed of motor response, constructive apraxia with a perdu pegboard with a ray, the perception with a hooper, attention. We have done a computerized attention tool with 13 subtests called the TAP and translated in 8 or 9 languages of Europe, in order to know what are attention resources, concentration, selective attention capacities, flexibility, divided attention, sustained attention, which are parameters we study with a computerized technique. So we can register omission, errors, tendency to tiredness, slowness, and then we assess memory, the working memory, but also episodic and prospective memory, and so on, with the Grober and Bush, with California Verbal Learning Test. Cognition is assessed with the WISE, revised, executive functioning with Tower of London, Tower of Hanoi, verbal fluency, Stroop, Wisconsin card sorting test, and so on. The behavior is analyzed and assessed with the NRS of Levin, language with the Boston naming test, token test, and the personality with we use MMPI. After 2 weeks, we are able to make a first sketch, a first photography of the patient, his strengths, his capacity, residual capacities, and we start to built up a project beginning with the wishes of the patients, the families, and then the team. But what is difficult is that the wishes from the trainee is often blurred, not clear, changing from one day to another. And sometimes the wishes from the family are quite opposite to the wishes of the trainee. And the team is also deciding that this patient is not able at all to make this project, and so it's very difficult to come to a consensus for building up a project. If a first sketch is built up, we try to put the trainee in a workshop. We built up 3 main workshops: group psychotherapy, collective sport, and a specific industrial workshop. These are functioning together with other small workshops for attention, memory, intellectual enrichment, problem solving, assembly projects, social independence, and also technical workshops like mechanics workshop, handicraft, and so on. The three workshops, the essential workshops, are the group psychotherapy, collective sport, and specific industrial workshop. I would like to give you some information about these 3 workshops. First of all, the psychotherapy group. Group psychotherapy are conducted by 2 therapists, a psychologist and a neuropsychiatrist, myself. The trainees work on topics proposed both by the group and the therapist. The trainee videotaped the sessions. This was a scandal as I came back from the United States. My French colleague said, "What? You are making videotapes with your training? That's not ethical." But it was not a real problem. I explain you why. The group of trainees was considered as a social and professional microcosm where operating rules are set up, which will lead to an agreement between the trainees and the team. The group works on verbal and non-verbal communication, mime, and gestures exchanged within the group, with the group members, the notion of cohesion belonging to the group, interpersonal relations, expression of self-esteem, self-image are also evoked. Role-playing is introduced. One plays the worker, another the foreman, another the co-worker. Roles are attributed at each session. One is given responsibility for time, another for place, a third of dialogue. A cameraman as well as journalists are appointed. Knowledge and know-how are shared. The trainees and the therapists watch the videotape and comment on it. After each session, selected objectives are proposed to the group. The workshop is aimed at reactivating the communication dynamics and restoring the TBI speech. Therefore, its content varies according to the participants, their personality and interests, their capacities and difficulties. We work on what we call in French a pragmatique du langage, pragmatic of language. I don't know, it's a good translation. It offers an opportunity to observe the impact of the trauma on communication, relation with others, management of social relationships, and each person's psychoaffective troubles. It enhances interaction, self-expression. It enables the TBI to come out of his/her isolation through recognition by the group. This is for group psychotherapy. And at the end of the training session, after 3 or 6 months, I give the videotape record to the trainee. It is his work. And so he is able to see his progress from the beginning to the last period. And there was no ethical, I never encountered ethical problems at all. The industrial workshop is also one of our specificity. The trainee, accompanied by an instructor, is integrated into the industrial workshop, which comprises several workstations, 5 days a week, 3 hours a day. The trainees are encouraged to it theirs by giving it a name. They give the name to the workshop. The industrial retraining workshop operates in 3 steps. In the first one, the knowledge and the ability to learn gestures related to different workstations are assessed. Each trainee has to understand and learn the different gestures required to manufacture a product. The method used is demonstration repetition. In each sequence, the instructor takes care of every trainee individually during half an hour, 3/4 of an hour, in order to explain to him, to her, the operation of a workstation and to allow him, her, to train at it. In this manner, the trainee discovers a new workstation at each sequence, and after 8 days, will have worked at all of them. These workstations are not presented in the logical order of manufacturing, but at random. In this first step, one can evaluate and videotape the trainee's behavior at work, but also the behavior of the monitor, make a gestural assessment and give him a visual feedback of his behavior. During the second step, the trainees work in groups to define the most logical and functional organization of the workstations, starting from the various component parts and ending up with the finished product. Thus, the instructor can assess how far the trainee have appropriated both the workshop and the task to be performed, how far they have understood the different manufacturing steps, how far they are able to plan operation sequencing and problem solving, how they conceive the overall organization. In this step, each trainee suggests his/her solution on the paperboard. Then the instructor steps in, guides and proposes a work organization method based on the flow chart technique, which is used to organize the action plan of a complex task. Using an analysis grid, this technique aims at sequencing the successive actions made by one or more trainees in a determined order. Any modification of this order, any omission may jeopardize the smooth running of a complex action and thus hinder its proper realization. The details of all actions, their nature, duration and order in the sequence, as well as the people involved, are carefully planned. The grid is then displayed and may be consulted at any time It is a reference for the analysis of production's error and flows. Starting from this organizational work, the group, together with the instructor, defines the workshop layout according to the chosen organization and proceed with the actual installation of the workshop to network the workstations. Each workstation is identified by a panel on which the contents of the task are listed in chronological order of performance. In the third and last step, the trainees are actually put to work. Each trainee is assigned to a workstation for one sequence and moves to another workstation at the next sequence so that each of them has operated every station at least once. The group is placed in a real production situation and has to make a finished product which will be delivered to the client. Each trainee has a follow-up sheet. I give you an example. In a packaging line of screws and bolts, for instance, the trainee can perform the task of storekeeper, reception, shipping, paperwork, preparation, packaging and quality control tasks. Daily productivity is measured, displayed, discussed. The presence for an entire 4-week period in this workshop is one of the innovative principles of this research. 4 weeks during which the young patients have to learn to find themselves. This is one of our methods. And another one is, no, I have no picture. Another one is what we call guidances or evaluation. After the elaboration of the project, we met together, the trainee, the case manager, the medical doctor, the psychologist, and we discuss in an interaction fashion. And we try to see if the patient is able to get over his anosognosia and if he is able to understand what is wrong with him. And another interesting point of this program is to put the patient outside the center for a few days, 1 week, to assess his, how can I say, his employability, that his capacity to interact with other workers, and he is accompanied by a tutor from our institution and met the tutor of the other institution. We work with that method with Peugeot manufacturing, the car manufacturer, and Alstom, the TGV, the fast train, and so, and it works very well. This is during 1 week. Then the patient come back and we adapt the project with the result of the analysis of employability. And then he's going back in another workshop or in the same workshop during 3 weeks or 5 weeks. And this is an enriched environment. And at the end, he come back, we make a reevaluation, new orientation, and we try to make an action plan. Either he return to work in the same company, in another company, another vocational tutor, a sheltered workshop sometimes, but I am against the sheltered workshop in France. They are not good. Vocational training, school education, or status quo. What we observed were failures of return to work. Behavioral difficulties are the most important. Anosognosia, attention and memory problems, but also slowness and tiredness. They are not able to work 8 hours a day, and they are not able to have enough productivity. So what we propose is half-time work and not full-time because of the deterioration of their quality of life. Our goal is to help them to have a better quality of life. We assess that if they are going back at work, re-entry to work, they have a better quality of life if they are working half-time. We also noted failures of keeping a job, difficulties in maintaining and using techniques of compensation they learned by us. After some weeks, after some months, they don't use our techniques and go back to their techniques, and so they fail to go ahead. Drugs, they take drugs, and if they were addictive before TBI, often they are, even if they stop their addictive behavior, they go back to drug intaking. The stress is also a big problem. So we have a workshop for training, for coping and stress coping, analyzing and stress coping. Depression, psychiatric difficulties, behavioral, adaptation, behavioral especially, and modification of the context. If the wife of the trainee is going away, if the professional environment change, then the patient is perdu, he's lost, yes. And this is a real problem. Voilà. This is a conclusion.